Hi, everyone. My name is Amanda Sake. I am Chief Advocacy Officer for the New York State Office of Mental Health. We're really glad that you joined us today. I know at a very busy time of the year to talk about an overview of adult peer specialist services. We have done this webinar before, I think like a year ago, and now at this point. And we wanted to provide this as a refresher, and we do have some new content as well as some frequently asked questions. And so this webinar is being hosted by PeerTech, which is a combined effort through the Academy of Peer Services and MHOTRS. All of our PeerTech colleagues can introduce themselves in chat. And I'm joined today by two of my colleagues who I'll let them introduce themselves. Liz, would you like to introduce yourself?
Sure, thanks, Amanda. Good afternoon, everyone. My name is Liz Beyer. I work together with Amanda for the Office of Mental Health. I'm the Regional Director for the Downstate area within the Office of Advocacy and Peer Support Services. Happy to be here.
And hi, my name is Dorota Carney. I am the Unit Director for Treatment and Integration here at Central Office. I'm glad to be here as well and answer some questions.
Awesome. Let's get going. So here are unfortunately Casey Carpenter from the New York Peer Advancement Network couldn't be with us today, but we have some information about that exciting new resource in this slide. The first question is just tell us about you. When folks joined, tell us in the chat. Oh, it's a poll. Awesome. Even better. So indicate your primary role, and it is multiple choice. Okay, so who do we have? So 5 peer specialists, 5 supervisors, 6 clinic directors, and 6 others. Awesome. Okay, great. It's great to know who's in the room. And again, thank you for joining us. Our objectives today are to help, in our definition of peer support is to also distinguish natural peer support and peer support services, to review the qualifications for adult, family, and youth peer support professionals in mental health and substance use treatment, to describe a little bit more what peer support professionals do and do not do, and to talk about our role on multidisciplinary behavioral teams. So this is new material for me. This metaphor story I've heard a lot of peer specialists use when describing peer support. This is new to me. And just to say off the top, I've been in this field as a social worker since 2005. And I am also a person with lived experience in mental health issues, starting with my first hospitalization after a suicide attempt at age 16. And for a long time in my career, when I was in school, I had a really difficult time in mental health services. And it was something actually for my career as a social worker, I really wanted to help people, and actually didn't want to work in mental health. because of the experiences that I had, wanted to still work in the sector. And my career took me on a journey. My first placement when I was in grad school was on an ACT team. I've run a PROS program. I worked in housing. I've worked in LGBTQ outreach, Ryan White funding. I've worked in a lot of places. And it wasn't until I was a PROS director and I was first supervising peer staff, and I was sitting in a peer support, one of my staff's peer support group, and she was talking about, she introduced herself. She was a nurse, and she was talking that she's also a peer supporter, actively using her lived experience. And I was like, whoa, I didn't know we could do that. And I had a supporting supervisor at the time, and I was able to take the training to become a peer specialist. And, the training that I have and the value that I have as a social worker, as a supervisor, I'm doing this lead up because it's for this metaphor, that I, have truly believe that becoming a peer, receiving peer support services myself, along with other treatment services, that the enhancement, and when I first really started to connect to my own personal recovery was when I became trained as a peer. I had been so traumatized. I had some really challenging experiences in inpatient hospitalization. I was restrained. I had a psychiatrist and a therapist who told me that I had very serious conditions and that I wouldn't recover. I really wanted to go back to college and just, be, and again, pursue a career in social work. And they told me to temper my expectations. They were coming from a place where they were trying to help, but I engaged very differently in my own personal recovery, where I saw, okay, I never want to go back to the hospital again, and kind of want to self-direct my own life, and not, receive any messaging that would kind of conflict with my own pursuit of my own recovery. And so I learned to engage with mental health as take your medications, because medications don't work for everyone, but they work for me. Tell the professionals, what they need to know. I'm in the industry, so I kind of, know sometimes what they need to say or what not to say. And when I became a peer and received peer training and, learned about the holistic aspects of recovery, the power of connection, the power of, empowerment and advocacy, is when I really started to engage with my recovery in a different way. And it's grown to now embody the values of accountability in recovery. And, being a peer supporter, and in my role here at OMH, with helping to support the practice of peer support and peer specialists is, an honor and a really special duty that we really appreciate, and appreciate working with our colleagues. So I say all this to say that I hope that this metaphor helps to kind of illustrate the kind of what distinguishes and makes peer support so effective. So we'll take you on a little journey. This is about a person who's stuck in a hole. So a person with a mental health issue fell in the hole and couldn't get out. A CEO went by as the person called out for help. The CEO threw the person some money and told them to buy a ladder, but the person could not buy a ladder because the person was in a hole. Next, a nurse came riding by on their bicycle. When they heard the person cry out, "Please help me, I can't get out," the nurse stopped and asked if they had any broken bones, open wounds, kind of do a triage situation. The person said no, and the nurse said they were late for work, but reassured the person that it would send someone for help. Next, a psychiatrist pulled up next to the hole. The person said, "Help, I can't get out." The psychiatrist said, gave them some pills and said, take this, you'll feel better. The person said, thanks, but when the pills ran out, they were still in the hole. And a little later, and so this is kind of a caricature of us kind of social workers and therapists. A little later, a therapist walked by and heard the person's cries for help, and stopped and asked, how did you get there? Were you born there? How do you feel about your parents? Tell me about yourself. So the person talked to the therapist for the hour, then the therapist had to leave, but they said they would be back next week. The person thanked the therapist, but again, they were still in the hole. A priest came by, the person called for help. The priest gave them a Bible and said, I'll say a prayer for you. They got down on their knees and prayed for the person, and then the priest left. The person was grateful. They read the Bible, but they were still stuck in the hole. Finally, a peer specialist happened to be passing by. The person cried out, hey, help me, I'm stuck in this hole. Right away, the peer specialist jumped down into the hole with them and said, the person said, what are you doing? Now we're both stuck in here. And the peer specialist said, it's okay. I've been here before. I know how to get out. So that illustration, I know it makes a little bit of a caricature of other professions, and by no means are we trying to diminish the critical role that all team members of all disciplines play on a multidisciplinary team. But the illustration hopefully helps to show the essence of what we do as peer supporters and how we're effective and connecting with people, and how we can be effective members of the team when we're actively using our lived experience in our work, when we're engaging with folks. Because I think most people, and if you think about your own personal lives, think about things that you've struggled with, and peer support kind of naturally is a human response when people are in a particular circumstance, reach out to others who've been through similar circumstances. And it's to help people deal with the same life challenge. So if you think about natural occurring peer supports, if you think about 12-step groups, AA, cancer support survivors, parenting supports, where people gravitate, and when someone who has been, who has walked the same path or says similar path and can say, I've been there, and a critical part of a peer supporter's practice is the use of our lived experience that then, as we work as peer supporters, becomes our lived expertise. And it becomes one of the critical skills that we use in our work in a variety of settings. Bereavement support, yes, thank you, Rita. Care providers can also support each other. That's a very good point too. So natural peer support, authentic peer support, genuine peer support, we've heard people call it on the names. It's really at the heart of it, and is available to people, in the community. And peer support services are distinguished because peer support in a service setting is billable services, and there are added responsibilities like job tasks, documentation, reporting, working with colleagues, and working under supervision. So it's a kind of the biggest distinction between naturally occurring peer support. And what we here at the Office of OMH have really tried to do with putting together guidance for the implementation of peer support services and through the work of Peer TAC and the Peer Advancement Network, is to help effectively integrate peer support services in a predominantly treatment setting, which is bringing something brand new and something that people may not fully understand into a setting, and to help kind of maintain as much of the integrity of that natural connection while still, performing, in a job, with these added tasks and responsibilities. And whether, peer support services, includes youth, family, adults, and older adults, and in the mental health outpatient treatment and rehabilitation service program in MHOTRS, the services are provided by certified peer specialists, New York certified peer specialists, credentialed family peer advocates, and credentialed youth peer advocates. And the Office of Addiction Services and Supports OASIS has a different qualification, SERPA, for addiction recovery peer advocacy. And SERPAs can work, and we have this a little bit later in the Q&A, SERPAs can work in MHOTRS program, provided, and this is a tip for when you're interviewing, provided they meet the qualifications for one of OMH's 3 peer credentials, and that they pursue it within a reasonable time frame upon hire. And again, this is a tip for hiring managers that, if you're to provide, support to individuals with mental health and co-occurring needs, is that, SERPAs bring a lot to the table, but we want to make sure that people working in OMH clinics are also receive the training to effectively do the work in mental health services. And to learn more about kind of the credentialing, with credentialing, all of this is free of charge to folks. So there's the training for the adult peer specialist certification is on the Academy of Peer Services, and the New York Peer Specialist Certification Board does the certifications. You can learn more about them there. And for the youth and family peer advocate credentialing, the training platform for the YPA and the FPA credentials is on CTAC, with a very close partnership with Families Together, who provides in-person training and approves the completion of the family peer advocate and the youth peer advocate credential. And in the peer support guidance, we only have an hour today, but in the peer support guidance, which we have a ton of links to, really encourage folks, if you haven't seen, to check it out. That really kind of fleshes out, because we get the question, well, what do peer supporters do? And these are just short lists, and it's expanded upon much more in the guidance, but what we do is we engage, we bridge, we support people through transition. We help individuals and support them in advocacy skills, and to help people to become empowered. We don't empower someone, we help them to become empowered themselves through, advocacy, motivation, connecting people to natural supports and community connections. We can provide assistance in pre-crisis and crisis services. We can assist with skill building and coaching. And in family peer support, all of the same, and to highlight parent skill development. And there's much more information in the guidance of, what spelling out what each peer discipline does in MHOTRS. This is actually taken from an article, and it's a really great read. And sometimes it can be really challenging. Peers with a ton of peer subject matter expertise, they're going to talk about a day in the life of a peer support worker. And so sometimes it's helpful to talk about the misconceptions and this is from the article, but I can quote this myself, and I've heard some doozies. I heard some doozies even this week that I was really shocked about. I was in a national group, this was no one from New York said this, but I was in a national group and they were talking about peer support, and someone said that they were really excited about peer support because they were inexpensive staff. And I'm on this work group with several of my colleagues in MH, and I was like, oh no. So, you know, it's not a paid friendship. It's a service. We're providing peer support service. It's not diagnosis specific. So, you know, it's the experience of, you know, different mental health experiences is very different. And, you know, we work with everyone. And so it's not we're paired with someone with a specific diagnosis. It's not a back to work or a work skills training program. It's or a goodwill bridging program. It's a real distinct profession, and it's, you know, for people that you're serving and people that you work with who might be, you know, interested in like giving back, you know, and working in this field and using their shared experience, by all means. That's what we want to do as we help grow the peer workforce, is that there's probably a lot of people that you work with that could have a meaningful career in peer support. But it's not just okay, work as a peer supporter for 2 years and then you can get back to work. And I hope that makes sense. We have a specific set of values and competencies. We work on interdisciplinary teams. We have a code of conduct, and really with a heavy emphasis on integrity. We come from a lot of different backgrounds. Some of us have different trainings. Some people come to the field like I have, you know, starting as a social worker and becoming a peer. Some people come, you know, GEDs, high school equivalencies. You know, a lot of people I've met that are peers kind of came from completely outside of the field, or they had a life disrupting moment with mental health experiences, and then came into the field to become peer supporters. So we really do come from a lot of different places. And really, to be a peer specialist, it really requires respect and acknowledgement of grassroots activism. And as long as there have been asylums, you know, and the first recorded instance of peer support was back in the 1700s at a French hospital, where the hospital director hired a patient to work, a former patient to work at the hospital, because he felt that, you know, having been a patient in a hospital that provided this level of insight and compassion that was unique in the roles of, you know, and couldn't tell you the roles of everyone in the 1740s. But ever since this has existed, you know, the need for this, you know, peer-to-peer connection has existed, you know, and the medical model approach, and I want to really kind of also emphasize this, does a lot. And what you all do matters. Again, every member of the multidisciplinary team plays an integral role in helping people in their resilience and recovery journey. And we don't want to take away from that. We want to be working in these settings, you know, in our capacity as peers. Recovery is not a linear process. It doesn't happen in a prescribed ways. And as peers, we're the proud product of all the pioneers who came before us. And we ride on the shoulders really of brave and daring activist individuals and dreamers. We support self-advocacy, we support autonomy, working within an individual on their own terms. We're conscious of biases and barriers that may influence their recovery. We connect meaningfully with people around wellness and quality of life. We encourage folks to speak freely about what works and what doesn't work for them. We discuss communication strategies, some things that have been effective for us in having our voices be amplified and preferences heard. We definitely talk about stigma. Unfortunately, we know stigma all too well, and the experience of trauma. Many of us peer specialists also know the experience of trauma, and that's another vehicle in which we use our story and that lived expertise of the work that we've done to help support individuals. And so what's the power of peer support work? It lives in letting someone know that they're not alone. It lives in walking a path together, unpacking complicated experiences about what it means to live with a mental health issue or a substance use issue. It's about celebrating diversity in all its gloriously messy, non-conforming iterations. And we, as members of multidisciplinary teams or interdisciplinary teams, and certainly as a peer working, for the Office of Mental Health, is, we are positioned to question the status quo, which can feel uncomfortable. But in the end, the status quo should always be open to investigation without feeling threatened. And this can help form strong, healthy bonds within a team and promote creative, individualized, person-centered approaches. We all want to do more. We want to do better. And our pursuit of excellence in mental health care would be less robust if the peer specialists weren't here. Again, not taking away from any the work that others can do, but just kind of illustrating what we can do in our role as advocates. So let's go to a real quick poll. How would you describe a day in the life of a peer support worker, peer support workers? Rewarding. Oh yeah, sorry. Yeah, those are asking for people to say in chat. Rewarding. Rewarding and challenging. Thanks, Liz. I can really relate to that. Using so much of ourselves can often, be quite taxing. Equal parts rewarding and taxing. It's a collaborative learning experience. Love. Difficult and gratifying. Love that. And soft. Difficult and potentially unpredictable. Strong back, soft front. These are very similar to what clinicians and other folks in the field would describe a day in the life of the work that they do and we do. Uniquely vulnerable, requires working our skills to enhance provision. Great. And so for peer service implementation to be successful in the MHOTRS program, teamwork is paramount in this service delivery mechanism. And it's, requires the combined, co-coordinated and dedicated effort of each member and every team. And as members of the integrated care team, peer specialists and advocates make contributions that assist with engagement, practical assistance to achieve and sustain skills, development of coping mechanisms, empowerment, and building relationships. And working in organizations, we support many pathways to recovery. We motivate through hope and inspiration. We respectfully hold different perspectives and question the status quo. Our key aspects in building multidisciplinary teams. And because of our lived expertise, can maybe see things a little bit differently, getting to the heart of the matter. Because, and I can speak to my work at the Office of Mental Health, is, pretty much everything I do is personal. I'll explain, is that, often in every conversation when we're designing programs and high level policy, I reflect upon, like what would my experience be like in this situation? And, like, what do we need and what can I draw upon from my lived experience and, the lived experience of all the individuals that we work with in our office to see, like, what would people find most healing, helpful, and supportive, and how can we build that into these multidisciplinary programs that doesn't take away or conflict with the service model that is hopefully becomes part of the model and an integral part of the work. But we have a lot of work to do in bringing peer support services in programs that traditionally, for many, 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 many years, have not included peer services. And so the investment, again, that we've made in PeerTech is and PeerTech will talk a little bit later about all the offerings that they make, but to really support you in the MHOTRS to successfully, and we hope that these resources help you to successfully implement or augment peer services in your programs. There'll be upcoming webinars that talk more about youth and family peer support, but to, kind of a little preview, because again, there are 3 distinguished OMH peer credentials: certified peer specialist, the youth peer advocate, and the family peer advocate. And the principles of youth peer support include that they're youth guided, they partner with young people, they promote independent recovery, they provide mentoring, they approach the work from a culturally curious and humble perspective, and focus on connections, individualized and strength-based. You could see that there's overlap, in the peer disciplines. They'll hope use purposeful engagement and purposeful use of their stories in their work, try to help destigmatize some of the experiences that they've had, promote inclusion, build relationships, provide the individualized support, and again, helps individuals and young people to become empowered. Yes, and Lori, that's a good point. It's not all peers do work on integrated teams. In our whole service delivery system, we have peer-run programs. We have many different types of work. And what we're here today is talking about the inclusion of peer support services in integrated teams. So thanks, Lori, for that comment. Family peer advocates facilitate knowledge, understanding, connections. They support caregivers in identifying needs and strengths of youth and families. They bridge successes of past with options for future continued success. They help to remove the stigma and feelings of isolation by showing caregivers they're not alone in their struggles. They help to increase self-efficacy by providing current information, resources, and appropriate interventions to assist caregivers. They listen without judgment to families' ideas, preferences, and decisions, while holding and acknowledging family struggles, their efforts and successes, and accepts and honors differences. And similarly, they can assist with providing skills in parenting, advocating, and decision making. Adult peer support, supports choice and autonomy. We come to the work with a purpose of mutuality, in that we're meeting people where they're at, and different, and not different, but a distinguished way of working with folks where it's not based on hierarchical roles. Like some of the things that we do in direct service, like assessment, diagnosis, even some things that we do in rehab or rehab assessments, where it's more of stuff that we're doing for the person, and in peer support we're doing with the person, and that mutuality is a kind of key component of how peer workers approach their work. So that means an equally shared power, which can be a little tough to navigate in a service system with there's kind of based on hierarchical roles, like I'm the treatment provider, you're the patient, et cetera, et cetera. And this is where we find when we implement peer services in traditionally treatment-focused settings, that this can be a source of conflict with the peer support workers and other members on the team or in supervision, where we hear people talk about, the peers have bad boundaries. Believe me, we've heard a lot of different things, or, that they're like, they're friends with the staff. I actually, had, when I ran a pros program, I had people that I supervised who would come to me to complain or to voice their concerns that that the peer staff on our team were taking clients away from them, where they were feeling a little threatened by the level of engagement. And it was something I was really glad that they actually came to me and said that, and expressed that concern, because it helped us to kind of look and to see, like, our roles on the team, and then to see, for me as a supervisor, to see, well, what could I do in the oversight of the program to help the social workers equally connect to the individuals served. And it shouldn't be an us versus them dynamic on a team. It's a multidisciplinary team, and again, with people performing their distinct roles. And so role clarity, again, is really important in that work. We meet people where they are. We help people to know what to expect in participating in services. We provide hope and choices to consider about what comes next. We can help walk people through the process. Many of us have walked through the same path, and share our peer values and perspectives with leadership and staff. So this chart comparison, and Liz, I always say that you do these slides better than I do. So Liz, do you want to do the next couple?
Sure. I wouldn't say I do them better, but I do really like this one. I think this one is really important because there's still so much knowledge that could be gained about what it is that peer work actually looks like and what adult peer specialists do. So think of it, we're not focusing on all the things that we can't do. We're just trying to highlight that some of these things are actually not in our wheelhouse. They're not in our scope of practice. And we substitute them for the things that we actually can do. So we use human language. That can be very difficult to do in a system that's very medical model oriented. I have worked side by side with peer specialists who, find themselves sort of using that language. People often feel compelled that they have to, because it's the only way for the other providers on the team to hear them and to listen. And that can be challenging to work around, but we're trained to not use clinical and diagnostic language, to the extent possible. We try to work with a person's strengths and abilities and maybe seeing things about that person that sometimes they can't even see themselves, and really pointing it out to them like, hey, have you thought about this? So looking past even just the skill set, like they show up to group, or, they have a strong collateral system. Like we try to look at the whole person and not just the things that benefit the system itself. So we're not in a place of trying to fix what's wrong with a person. And again, we can sometimes get really excited about the connection and want to do that, because that's, pretty much what we're all being tasked with in some ways, but we stay away from that. Interact in ways that are mutual and reciprocal, like Amanda said. So that can be, again, challenging to do. We're already being placed in roles that are hierarchical, but to the extent possible, we try to come from that place. One easy way for us to do that is by asking the other person's permission before we share information with them, or before we take any action, even if it's what the treatment team is suggesting, just to get that person's okay that, yes, it's okay to have this conversation. Yes, it's okay to move forward in this particular way. We work with the person on their recovery plan, and hopefully really an overall wellness plan. So not just things that are geared towards system, but what is going to benefit this person over the course of their entire life. Because there are other things that get in the way with why someone may not be engaging with us to the extent that we would like to. And we can support them around those things as well. Supporting many pathways to recovery. So that really requires all levels of sensitivity. Not everybody is going to be excited about taking meds and going to a program. There are other things that people want in their lives in addition to that. And sometimes their response may be no. And it's our role to support that person in figuring that out as well, and articulating that to the best of their ability to the other people on the team. Motivating through hope and inspiration. So that doesn't mean that we're never making mistakes. To Amanda's point, recovery is not linear. So oftentimes we hear people say, we're modeling recovery. I prefer to reframe that to say, we're sort of holding place with you around what it can look like. And sometimes you're going to see the times we're messing up too, and the things that aren't working out for us, and the things that aren't going as we'd planned. If we're really going to be honest about recovery, it's all of it. Not just, but that provides hope around what's possible, because you can see people struggling to work through it and have those victories as well. Have cultural humility and curiosity about each person. So really no way to ever be fully culturally competent. Even within groups, there are things that are unique about each individual person. So coming from that place of not knowing and asking is part of what we try to include in our practice. What does this look like for you? Even when I'm a peer and I have some idea of what you've gone through, I don't know exactly what you've gone through. So asking, what does this look like for you? This is what it looked like for me. We have different boundaries than clinicians are trained. So sharing our lived experience is a part of the role. What that looks like depends on the person, depends on what's appropriate in that situation, and it's meant to be intentional. But we do tend to have more freedom around that area than the way clinicians are trained. We respectfully hold differing perspectives. Amanda and I do this all the time. We don't have the same ideas about everything, but we can have those conversations and it makes sense. And then this to me is the most important. We help the person to find their own voice, not where we're put in a place to always have to advocate for someone. The ideal is for that person to be able to do that for themselves in whatever way that looks like. But sometimes people need a hand with that because they're not feeling great and they're not feeling like they can do it, or they feel overwhelmed in that situation, or that's not their particular style or how they were raised to do things. So this is what we do. And this is something that is it's a practice. It's something that requires practicing, which is one of the reasons why we try to stay away from these other things, because we are trying to take that natural peer support and figure out ways to include it into a system that is based on billable services. So that is a practice that requires, we have more. Okay.
We do have more, but we're running out of time. I was like, ooh, this time is flying by. So maybe we could share the slides for the other things to help that. But thank you, Liz. That was awesome. I want to get to the Q&A for Dorota's section. There's going to be a whole learning collaborative on supervision through Peer Tech, so stay tuned for that. The Peer Workforce Advancement and Mentoring Network. Please post your jobs on the job board. And this is a resource that's going to be available to really support where Peer Tech is supporting the implementation of peer services. Peer Advancement Network is working to support the peer workforce. So sign up for updates. Yvette, the director's contact information is on the slides that you'll get. Okay, Dorota, do you want me to drive with the PowerPoint?
Yeah, that's fine. And like I said, I don't know if we necessarily need to read the whole questions, but I mean, I think just the kind of general themes of the questions. So in interest of time, if we want to leave a few minutes at the end for people to ask. But I know, like, for example, the first question is around pre-admission and open access. And these are some of the questions. So if you want to skip to the answer, I can give you guys a quick overview. But yes, peer support services are billable pre-admission, and there's no limit in the number of those services that are can be done. So they don't count towards the clinic pre-admission limits, and it doesn't like activate the startup time for which the assessments and a treatment plan should be completed. But I just wanted to emphasize that there must be progress notes, and those progress notes are co-signed by an LPHA, licensed practitioner of the healing arts. And that really is because these pre-admission visits are intended for engagement and outreach. So if a person says, no, I don't want to go to services, then no, and we're not engaging and we're not providing that. But it's for people that really are on the fence of like, do I want treatment? I'm not sure. Then, of course, as kind of Amanda described, is peer services are really beneficial in engagement and talking about some of that stuff. So while there isn't a limit, that signature really is saying that yes, we're doing these services to really engage the individual and kind of support them at that time. So so that's the long and short of it. Questions of
Dorota, do you want me to just do the answers? Would that be easier?
Yeah, sure. I mean, and people can kind of see the question and ask them on their own time. But yeah, so kind of around accompanying a person to appointments, we've had questions about different scenarios around that. And so the quick answer is those peer support services, they can happen like before or after appointments, and whether that be a psychiatrist or a psychotherapy appointment, or really any Medicaid billable service, but it can't happen at the same time. And just the logic around that, some examples we've received is maybe if somebody's nervous about going to the dentist, maybe, a peer might talk about their experience and how they got through going to the dentist. And so it's not that we're just driving them to the dentist and that's our role, right? Peers are talking about being there with the person, walking them through what their struggles have been and kind of how to get through those. So yes, they can kind of assist, before or after appointments. It just can't be billed concurrently with some other Medicaid billable service.
And if they're providing advocacy, they can be there if the individual chooses it and wants to be there, but it just can't bill, double bill for the service.
Yeah, that's a great example as well. So for utilization thresholds, we have a couple different questions around this. So actually there's two back-to-back utilization thresholds and annual limits. So peer services, they don't count towards the utilization thresholds, just making sure that you're billing the appropriate rate codes around peer services. And then next question is just around annual limit. Same thing. There is a 12 unit limit per day, but that doesn't count against your utilization threshold for the year. And there's definitely the link there that will be available to you if you have more questions. And Amanda, thank you for answering this question around if a SERPA is billable. So of course, and that was a great plug that for hiring is that as long as they qualify for the OMH peer certification and that they're working towards that, then they would be it would be allowable, but they do need to work towards that credential. And I'm sure your agency would have policies around timelines and what would happen if they don't follow through with that.
And it's just another tip for when hiring, because you can't ask an individual about their personal lived experience, but by knowing about the peer credentials and the qualifications, we could share that with the potential employee, if they're a certified recovery peer advocate, that's qualified and are working on this, then we can get hired. So that's a way, and Peer Tech has supporting hiring toolkits and the like.
Yeah, exactly. Great resources. All right. And so about adding, we've been asked about an operating certificate. And so as we know, peer services are an optional service. And so they're not required, they don't require any type of pre-approval. And so they're not included on the operating certificate. I just did want to note that, we have been viewing some of the data on who's starting to provide peer services. Obviously, we're interested. We're really hoping it's getting out there. So we are taking a peek. And so, down the line, we could potentially provide some technical assistance to you if you are implementing it. And of course, I'm sure Amanda and her group would also be more than willing to kind of help, with what that might be and look like. So it's not an operating certificate. It is an optional service. And of course, we'd love to see that being implemented across the state.
Yeah. One of my favorite things to do, and I'm not pandering, is working, Dorota, with you and your team, and Julie and the kids team, and Stacey and everyone, to been amazing partners in the successful implementation. And so, yes, and with Peer Tech, with us at OMH, yeah, we definitely want to know who's providing peer services or planning to.
Exactly. Yes, for sure.
There's a question from Amanda in the chat that actually corresponds to this question.
Yeah, sure.
So Amanda's question is, how do you bill for pre-admission? The person would not have a file to leave notes or insurance info in the system. I'm sorry, but this question was, are peers supposed to be part of the pre-admission phase?
Yeah. But just to hop to the question. So, there is rate codes, and I'm sorry, I'm not as hip to all the codes, but there are codes for peer services. And so when you're billing for those services, that's why it doesn't trip the thresholds. It doesn't trip, the clock for clinical services. So there are peer codes that need to be used. And so that's how you can bill pre-admission for those. They just don't count towards the limits. And then there was a question about billing for groups. So I think it's the same piece, that, with groups, there's also rate code specific to peer groups. And so for this next question about pre-admission, this is an important question. So it's definitely, again, the goal of those pre-admission services is really engagement. It's around outreach. So that's why it's allowable, indefinitely if it's helping support somebody. So while it's helpful, it's not necessarily required. And so, it's definitely a part of that relationship and that multidisciplinary communication between peers and the clinician about, this is how I'm attempting to engage the person, or this is the outreach I'm doing. And so really, if people are like ambivalent or undecided about if they want to join a clinic, but it's not required for sure. And I think that actually kind of transitions into our next thing about pre-admission for waitlist. So the purpose of those peer services need to be clear. And I keep saying outreach and engagement because that's really what that admission is focused on. And so, if somebody's struggling on, I don't know if I'm going to enroll, then, that's something that we can support folks with. But it's not just, peers aren't meant to just be a check-in kind of placeholder while people are waiting on a wait list. Unfortunately, that's not, Amanda, I mean, if you have any other thoughts, but I don't know if that's necessarily the role, right? We're not kind of like wait list watchers. So it's really about engagement and outreach. And so, definitely working with your team on exploring what that looks like for different folks for sure. Something to be mindful.
Nail on the head, Dorota.
Right.
Is exactly what I would say.
Okay, great. And then for contracting for services, yes and yes. You can absolutely contract with peer-run organizations. You can contract for supervision. I think a couple of the key points is that we still want to have that integrated approach. And so, we're working together. We're having a comprehensive, holistic, and person-driven plan We're still needing to work together. We're still going to want those peer-run organizations to be part of the multidisciplinary team, and it doesn't mean absolve a provider from like still being responsible for what that care looks like. So it's definitely going to probably take some planning to make sure that they're included in decisions. They're part of the multidisciplinary team. We're coordinating the care for the person, but that's both of those, both for contracting, for supervision, and with peer-run organizations to provide the service is definitely allowed. And last but not least, we have some questions around treatment planning. And again, you'll have these slides so you can kind of review the information. I'm going to kind of answer these questions a little bit like out of order. So basically around the treatment plan, obviously, peer support services really do need to be used in a like really planned and in an intentional way, right? So there might be situations where the services are planned in a bigger to address a lot of the goals and the objectives, preferences, and those are definitely must be listed in the treatment plan. But there might be kind of like a short-term situation. I think we gave some examples, maybe a significant clinical event that occurred, some type of change in their level of engagement. So there might be like a activating event that might that peer services will be a big part of. So there's likely that peer services are included in the treatment plan as maybe or part of an objective to achieve something. So it might be in there, but it's not. It's how it's documented might be a little bit different than if peer services are a kind of a modality throughout the treatment plan. And then there's kind of like a third situation in which maybe it's like a one-time or a one-off or some type of ad hoc peer service. There was a couple examples listed, like representation for a special committee on special education meeting, some type of education or connection. So maybe like a one-off where a peer service is needed. So maybe it might not necessarily be documented clearly in the treatment plan in that case, but there would be some reflection as to why it was necessary, whether that be in a progress note or maybe the multidisciplinary team discussion said, hey, this situation came up. Amanda would be a great resource. They're going to go work with this person. And we documented that, and that's why. So it's maybe not long-term, but a situation that arose that may indicate a peer service could be indicated. So regardless, again, we're still focusing on the individual and what they need and what's best in their best interest at the time. And the other thing in terms of the treatment planning, so ultimately, clinicians are responsible for the treatment plan and what's in it. And so peers might work with the clinician to kind of update information. And again, back to that multidisciplinary team and working together. So that I actually realized we're at time. Hopefully we answered some outstanding questions that folks have. And if there are other questions, if they're added in the chat, definitely we'll be sure to answer them. And it sounds like we'll probably give out some notes. So if there's anything else we can answer for folks, we'll be more than happy to.
And thank you, PeerTech, and please check out PeerTech if you haven't already. Sorry we took you right to time, but thank you so much for joining us. Be on the lookout for future PeerTech trainings across the lifespan, and we hope that everyone has a safe, restorative, and healing holiday season.
Take care, everyone.
You too.